Good afternoon, everybody, and welcome to our webinar on trauma-informed care, a training for treatment providers. Let me start off, by the way, and say we really apologize for what happened last week, and we know it was frustrating, and this is our attempt to make amends, so we're really glad that you came back. And you'll obviously be invited for tomorrow as well. So thank you very much, everybody. We are glad that you could come. Some of you may be where there's a nor'easter. We are warm in our office, not looking out the window. So glad you're here. Let me just repeat a couple of things as we start to go through the webinar. The ATTC stands for the Addiction Technology and Transfer Center Network, and we are one of the 10 regions throughout the country. We are located at NDRI, National Development and Research Institute, and we'll find out, by the way, where you're from, but for some of you who are in the New York area, you may have been to trainings at our place. For today, we'll be here from noon to 1:30, and then tomorrow, same time, part 2. And another thing to keep in mind is this is the first in a series of webinars that we're going to be offering. It's later on this month. Diana Padilla is going to be doing a training called Cultural Elements with Hispanic Adolescents. And in April and May, we're going to be doing more. I'm starting to think about doing something on methamphetamines or co-occurring disorders or ethics. You can even, I won't say email me, but tomorrow when you get the evaluation, you can write topics that you would like to see, and we will try to meet those needs. So we are really glad that you are here. So there's my picture. And one of the reasons I have been doing these trainings, I'm also here with, oh, I forgot to say, if you did part 1 last week, this is part 1 again, so you do not need to repeat it. And we have records of that, and hopefully you'll come back tomorrow for part 2. So this today is for people who were closed out, unfortunately, of the training last week, and there were a fair amount of you. So sorry for that confusion. So there's my picture still up, and I have been working in this field for more than 25 years. And one of the reasons I'm doing this topic is that I have done a lot of training on substance use, mental illness, and HIV. And I worked on an AIDS Institute contract where we did a lot of work around trauma for people with HIV. And also, as some of you know, in the DSM-5, now we have a whole chapter on trauma, and that is some of what I have done a lot of trainings. Also, last year, I was working at a CREA, which is another AIDS Institute contract, and we did some courses on trauma and MSM, men who have sex with men of color, because the statistics on LGBT people are very high around trauma, around depression, and smoking, suicide, a whole host of things. So some of that information we'll try to talk about today, or maybe we'll do a whole nother training on it. Paul, would you like to say hello and tell people something about yourself?
Sure. I'm fortunate. My name is Paul Warren, and I'm very happy to be here with Mary today to help her with this particular webinar, offer her support, and help her with the questions that you send in. I'm currently the Deputy Executive Director here at NDRI, and one of the things that I get to work on currently is our Training and Practice Implementation Institute, which is specifically geared toward motivational interviewing and sustainability of practice. Very happy to be here with all of you today and having this opportunity to work with Mary.
Thanks, and I'm glad you're here too, Paul. All right, let's go over some of the information about CASAC hours, because I know that may be of importance to you. So here are a couple of things. I just want to go over also to make things not so confusing, but people who have the link for today, so if you have the link for today, which you do because you're on, you can use that link for tomorrow to come back to the program. We already said that if you took this course last week, you don't have to take it again. And one thing too is I know that some of you are at, maybe there's one computer and a few people. And what would be helpful to us is when they're, and I'll tell you how to do this when we look at the questions and how to write in, is if you would type in your names, and then we will have a record of it so that you can get your certificates too.
Somebody writes in that is there a particular sign-in sheet for today so you can get credit for today's attendance? The fact that you're on the webinar, and as long as you stay for the entire webinar, the system will record that. So that essentially is the sign-in sheet. Touching on what Mary just said though, if there are more than one person at a computer, because you only have one computer at your site that you're using, by all means, type in the names of everybody who is attending the webinar today, because we want to make sure that A, they're registered, and B, they're also getting credit.
Cool. So as some of you know, you do have to attend both sessions. You'll be getting 3 CASAC hours. And good, I see some names up there. Thank you very much for getting that to us. Now, tomorrow, you will receive a link for an evaluation after the second session, and then it'll just be important for you to send that link in so that we get the evaluation. When we get the evaluation, then Tree Chapel, who some of you know from always sending you the registrations, she will send you out a certificate in about 3 business days. So when we get it, as I said, we'll generate a certificate.
Right. So no certificate unless we get the evaluation.
Definitely.
Okay.
So, right. It's one of those things that is part of our grant. Yeah. We need the paperwork. We can't give partial hours, by the way. So if you only complete today and you can't complete tomorrow, we can't give you an hour and a half. We'll need you at both times. If you feel like it's something that you want us to repeat, we could do it in person. We could do it at a webinar again. We're here to help. We already went over that. So those are just some of the things to keep in mind. And I know people want their hours. All right, what are we going to do today? Now, just as a beginning, this really is like an appetizer course on trauma-informed care. So what we'll start to do today is we'll help you understand, and some of you are already familiar with this, by the way, that we'll be looking at what's the scope of trauma, what's the definition of trauma, how does trauma impact on your clients. We'll also look at the ACE study, which stands for Adverse Childhood Experiences, and we will start to look at that study and how that has really influenced some of the work that we've done on trauma. And then finally today, we will increase knowledge about trauma-informed care. So it's a term that we talk about a lot, and we'll, by 1:30, you'll know what that means. Next week, by the way, or actually tomorrow.
Absolutely.
Sorry, we did this last week, as some of you know. We will also be dealing tomorrow with the biopsychosocial aspects of trauma, the triggers for trauma, what you can do, and we'll review some of the evidence-based practices. So if you have questions about that, you can hold on to them, and we will work with you on that. One thing too, this is about trauma-informed care, and you may have heard this term, is hurt people hurt, healed people heal. So that is kind of the mantra of some of the trauma-informed trainings. So we'll start to look at what the definition of trauma, and people have a variety of definitions, and we took this from TIP 57. SAMHSA, which stands for the Substance Abuse Mental Health Services Administration, has published a lot of manuals, treatment improvement protocols, and one of the ones that we've used, or I've used a lot for this training, is called Trauma-Informed Care and Behavioral Health Services. The good news about the tips, by the way, they are free. And so if you just Google tips, you can download them, or they'll send them to you for free. So what is trauma then? So as this definition starts to look at, is that it is the personal experience, it's an event, or for many of our people, it's a series of events. And for them, it involves actual or threatened death or serious injury. That sounds kind of general in a sense, because one thing that can happen is that the key is that it frequently produces a sense of fear or helplessness. So the reason I was kind of choking on that one is because sometimes a person can experience a trauma, another person can experience a trauma, and they have same event, and they have very different experiences with that. So it's one of our trainer answers. It depends. So the person's response involves, as we said, intense fear, horror, and helplessness. One of the things, by the way, a couple of things. One is trauma affects people of all ages, all races, ethnicities, sexual orientation, gender, geography. So nobody really gets out of experiencing trauma. And one of the things in the DSM-5, which is the DSM, Diagnostic and Statistical Manual of Mental Disorders, when they were redoing the discussion, and we'll have something on this on post-traumatic stress disorders, they took out extreme fear. And you know why? Because they wanted to have people who are first responders or people who are Navy SEALs, they don't experience fear. That's not like the first thing that they think about, even though they do experience post-traumatic stress disorder. So you don't have to have intense fear, but for some people, it's important. So here's kind of the picture view. You've got an event, and in this picture, what do you see? You see three people, everybody's got a different response. And I remember after hurricane, it was not the recent hurricane, I guess it was Superstorm Sandy, there were two women who I met. Each of them had experienced the hurricane. Both women lost their homes. One person was okay, and the other struggles even today with post-traumatic stress disorder. So you kind of wonder, what happens? What causes that? And we'll be looking at risk factors. We'll be looking at resiliency factors. One of the most important resiliency factors, by the way, is social support. So a lot of the work that you do to help people in terms of developing social supports is a resiliency factor for trauma. Another thing too about trauma, when I was saying that it really depends on the person, we don't want to minimize people's trauma. So for example, I was doing a training once, Paul, and somebody was telling me that in their community, people get used to hearing gunshots. So they didn't look at it as trauma, but can it be traumatic?
Sure.
Absolutely. So we wanted to kind of look at the whole picture and take it from there.
And like you said before, it also really depends on that personal, that unique experience that that person has had. Some people may experience that as traumatic, others may not.
Exactly. And so that's why it's important to kind of look at the whole picture. So now we are going to ask you to write in. So would you please write in, what are the kinds of traumas your clients have experienced? What are the kinds of traumas your clients have experienced?
Rape. Domestic violence, poverty, single-parent homes, physical abuse, sexual assault, death. Somebody else writes in rape. Lack of education, drugs, being shot, death of a loved one, watching overdose.
All right, that's a big one.
Homophobia and racism, homelessness, financial, car accident, emotional abuse, physical abuse, sexual abuse, poverty, HIV diagnosis, homelessness, parental abuse. Absolutely.
Neglect.
Hunger. Yes.
Yeah, and I think it's important, actually.
Financial abuse. Right. What were you saying, Mary?
Well, I was saying it's interesting too that many of you have written in some of the traumas that are very severe. Some are still severe. They look a little differently. Like, for example, neglect and hunger. People don't see that as much, and yet that is really one of the big things around trauma. And for many of our people in New York, and we didn't ask you where you're from, by the way, is that many people are dealing with food insecurity. They don't know when their next meal is going to come.
Somebody wrote in cancer diagnosis, police brutality, and illness, or illnesses of all different types.
Right. I was sharing last week in the program that you missed is that my sister teaches at a high school in Chicago, and she was asking, I don't know if she was doing it for statistical purposes because she's a math teacher, but she asked people to raise their hand if they had been the victim of stop and frisk. Every single young man raised his hand.
Wow.
So
somebody writes in hurricane, loss of home, divorce, and separation.
great. So all of the above.
Yeah, and a really informed list.
All right. So some of these you've already started to mention, and this comes, by the way, also from tip 57. And I will say that there probably are a lot more traumas, some that you mentioned, and they broke it down by natural causes, accidents, intentional acts. Oh,
somebody writes in riding the subway in New York City. And you know, for some folks, that actually can be traumatic.
Right.
Depending on what's happened to them in the subway.
Oh, yeah, and you said that was serious.
Yeah,
definitely.
Absolutely. Yeah.
Gang
intimidation.
Yeah, that's another big one.
And police stops, you were mentioning the stop and frisk. Absolutely.
Right, so there's a whole, again, series. And if you kind of look at the next slide, that, as I said, there's broken down into natural causes, accidents, and intentional acts. And some of the research, by the way, thinks that it is easier to heal from natural causes. Anybody want to write in why you think that it might be easier to heal from natural causes rather than accidents or intentional acts? You want to give it a try?
Somebody writes in lack of self-blame.
That's one of them.
Yeah, absolutely. Because they are non-personal. Yep. It's not another person directing something at them. Yeah.
Right.
Okay.
And that's what people have said, by the way. And it doesn't mean that people don't suffer trauma. It just means that sometimes people will look at it as not caused by another person, or maybe it was from God, or whatever people believe around that one. And just a couple of things to add. All right.
Because you can replace material things, but if something intentionally is acted out on you, that makes a very sense. Different, yeah.
Right, as some of the ones on the right. Just in terms of the accidents, by the way, and somebody mentioned about being in a hospital, there's been a lot of research on people waking up in the ICU. And what could happen is somebody has a car accident or a stroke, and they wake up in a hospital in an intensive care unit, and they're in a small room, it's dark, they're attached to all kinds of machines, and they don't know how they got there. So that sometimes for the nurses or the doctors who work there, yeah,
somebody writes in, there isn't a control factor, right, because you're powerless over a natural cause. Also, some types of trauma are caused by someone that was seen as loving or caring for you.
That's a really good point, and something we will look at when we compare some of the traumas around men and women. So as you can see from the list, that there are accidents, and I was telling a story once about how there was an oil spill in Alaska. It was a while ago, but what happened was, you know, I'm in my house or my apartment in New York, and you see the oil spill in Alaska, and it's far away, so I don't think about it as much. But one of the things that really affected was that the Inuit, the local population, they depended on the sea for fishing. They depended on it for food. They depended on it for spiritual practices, so that the impact of something like that, which is deemed, quote, an accident that somebody gets sued for, really impacts a whole culture.
Yeah.
And then intentional acts, and these were many of the ones that you said. And what else could we add there? I think I would add, and actually you already said this, about food insecurity, about neglect. And many of you are working with people who are victims of sexual assault or survivors, depending on what kind of word that you would want to look at or add. Is there anything people would add?
Being kidnapped.
Definitely.
Absolutely. Intentional act. Yeah.
Cool. All right. So,
watching the 24-hour news cycle, especially a child. Yeah.
Yeah. What do you think?
Being exposed to the images and the, yeah.
Right, that makes sense as well. So you can see again the variety of severity, and we'll talk more about that with resiliency factors. Now, one of the things about the differences between men and women, and I will say that what do they have in common? Both men and women have experienced high levels of traumatic experiences. So it's not that it's one gender or not. Everybody has really experienced high levels of traumatic experiences. One of the differences, by the way, though, is that for men, that they are more likely to report physical violence by people they don't know. And somebody said that before. I think they were talking about being abused by somebody you love.
Yeah. Yep, it was mentioned that that also some types of trauma are caused by someone that was seen as loving or caring for you.
Yeah, and that's a real typical thing for women. So they're more likely to report physical or sexual abuse by somebody they trusted, by somebody they loved. And for those of you who work with people with borderline personality disorders, there's a fair amount, I'd say about 60% of people have been sexually abused. But you could kind of understand or be compassionate that if somebody loved you and then they sexually abused you, wouldn't that be confusing? So that's one of the differences. I will say, though, that for prison, it's different. And there's a woman named Lisa Ndjavets who's written Seeking Safety that some of you use for substance use and post-traumatic stress disorder. And what she said, and I thought this was interesting, that when women go to prison, they feel safer. Why? Because they may be coming out of relationships, domestic violence relationships, threats of violence from pimps, homelessness, and yet for men it's the opposite. So they will anticipate not being so safe. So it's really a different kind of thing. Going back, I was thinking for the example about people who are sexually abused by people who everybody trusts. Look, for example, at the United States gymnastics team. There was a doctor who supposedly was a really good doctor and everybody trusted him, and look at the amount of young people that he abused. But I'm sure that the parents trusted him and they're struggling, I'm sure, with their own guilt around that. And what I had heard was he made up a PowerPoint presentation for people on why he had to use some of the things he did which were sexual. You know, from a trainer point of view, we make up PowerPoints, but he just was grooming people. So that's one of the differences. Another person, by the way, if you're interested in gender-based treatment, Stephanie Covington has done a lot of work on women in prison, women out of prison, and differences between men and women in terms of some of the differences around trauma. So, should I have you raise your hand if you've seen or read this book, The Diagnostic and Statistical Manual of Mental Disorders, the DSM-5? All right, I see hands going up. And one of the things, by the way, that some of you are familiar with is that the DSM-5 has a separate chapter on trauma, and it's called Trauma and Stressor-Related Disorders. And that's new because in DSM-4, they had those disorders, but they were kind of linked with other kinds of things. And the way they break it down is they look at acute stress disorder. And the key, by the way, is that acute deals with time and a shorter period of time. So for example, you know, every time we do this training, there's something that's gone on. And so if there's a hurricane or some kind of storm, people will start to experience it for a while. And let me just say that not everybody gets a diagnosis. Some people go through a trauma and they're fine for a variety of reasons. Post-traumatic stress disorder. Actually, I'll ask people to please put your hands down if they're up. And then to raise them again if your clients are dealing with post-traumatic stress disorder. Oh.
Many hands have gone up for that. Absolutely.
And it's, again, not surprising. And one of the differences with PTSD is that it occurs after the event. So if acute is shortly, post is after. And the symptoms really become pervasive, and meaning they really affect a person's everyday life. So some of the criteria include things like intrusion. So somebody is in a training, or they're at work, or they're in the supermarket, and they start to have thoughts of what happened. Avoidance, meaning they stop or isolate. And I mean, one of the things that happens, sometimes avoidance can be healthy. Somebody was telling me a story about how they, when the holidays come, the person who abused them is at the holiday dinner, and they're expected to serve them food. Now, if somebody said to me that they didn't want to go, I think that would be okay. But if, for example, people stop going to work or taking care of their children, or doing the things that they have to do, it becomes problematic. Negative alterations in cognition and mood, fancy term for sometimes people are irritable. And, you know, sometimes you deal with somebody who is irritable and you're taking it personally when it really isn't.
A couple of things people write in. Somebody writes in that societal expectations of different gender roles may cause men not to report things like rape, as society would then victimize them. And somebody also writes in that, can a person experience acute stress disorder even after 4 weeks, or is it then considered PTSD? And again, I think that would depend on who was sort of looking at the symptoms,
right,
and the duration in terms of the specificity of the diagnosis.
Definitely. And yes, we agree that social expectations or gender roles really cause men, by the way. In fact, on one of the next slides, we'll start looking at statistics, and that might be one of the answers as to why men underreport. Another thing you might see too is alterations in arousal. And when tomorrow we talk about the biopsychosocial aspects, we'll look at, for example, why people are always kind of quote on. And sometimes it might happen that you go up to somebody and you touch them and they jump. They have a high startle response. And that can be that they're always on. I was talking to somebody who had been in Iraq, and think about it. If you're in a place and for 24 hours a day, you have to always be on and always be worried about your safety, and then you come home, it takes a while for people to work that out.
That makes me think of somebody, the idea of somebody being vigilant, that they're constantly vigilant about their surroundings.
Exactly. And that would be a good word to, I think, explain that.
Yeah.
So here's something that also affects our people, and it's called complex trauma. And what does it say? What does it mean in plain English? You got some words up there, but you look at kind of how common it is that somebody was maybe abused as a child. They were,
hypervigilance.
Exactly. Yeah. So that somebody might have been abused as a child or neglected as a child, bullied as a teen, a sexual assault victim as an adult. And so the more traumas a person has, unfortunately, there's no immunity to trauma. So that if you've experienced a lot of traumas, that people will be affected by future traumas. I don't know, does that make sense what I just said? But it speaks to, again, of susceptibility. And many of you know some of the histories, or you get the histories as you go along. And so you want to kind of keep your antenna up about that. I will say the good news about trauma, by the way, there's hope for recovery. People recover from trauma. And sometimes people have recovered from traumas like you'd think that no one could ever get over. But with the right treatments or the right social supports, people do okay. So now we're going to ask you to write in again. What is the percentage of your clients who have experienced trauma? What is the percentage of your clients who have experienced trauma?
90%, 75%, 100%, 90%, 75%, 99%, 85%, 75%, 100%, 50 to 60%, 80%, 100%. So about 50% is the lowest we've had so far.
Right.
And that's, over half, or half at least.
Right.
So somebody writes in probably about 60%. So a lot of folks that we have the opportunity to work with have experienced trauma in some form or fashion.
Definitely.
Yeah.
One of the things too is that the National Center says to assume universal precautions around trauma. What do they mean by that? They mean that assume that everybody who comes to see you has experienced some kind of trauma, including us, by the way.
Yes.
So no one escapes, and I think we'll talk about it either later on or tomorrow about dealing with one's own trauma when you're dealing with people who have experienced trauma. So this part we'll talk about the Adverse Childhood Experiences Study, the ACE study, and usually when you take a course on trauma-informed care, they always refer to it. And so let's talk about what it was, why we did it, or why they did it. And here's some things to keep in mind. There were two researchers at Kaiser Permanente, Anda and Filiti. One actually was a doctor who worked with people who were obese, and the other worked for the CDC, the Center for Disease Control. And what happened was that they were studying people who lost a lot of weight. So people would come and they'd be morbidly obese, or that's the term they would use. They'd meet with them, they'd go on these special diets, they'd lose a lot of weight, and then they looked at it, what would happen later on. And this is before bariatric surgery, by the way, where now people you have to go through a psych eval to do that. So they were working with two sisters who were Latinas, and what they found was that both of them lost like about 80 pounds each. So they're like, success. And then 6 to 8 months later, guess what? The women gained the weight back. So they were confused. They were like, is this a genetic thing? Is it a cultural thing? What do the two sisters have in common?
And if you want to write in, what do you think perhaps the two sisters had in common? Be interesting to see what people's thoughts are about this. Or you may know because you may be aware of this particular study. Yes, women were sexually abused.
Exactly. They were abused by their father, and so their gaining of the weight or maintaining of a lot of weight was their way of protection. There's been a lot of studies, by the way, on women who have been raped and what happens afterwards. So it's this gaining of the weight is a way of protection.
Mm-hmm. And they had, both of the sisters had experienced
exactly
the sexual abuse.
And that's what people wrote. So they looked at some studies. So here's what they did. They had about 17,000 participants at Kaiser Permanente, and it was a confidential survey. And Kaiser Permanente is out in California, so it's mainly people from the West Coast. And they asked them a lot of questions about their childhood experiences. And what they meant were, in terms of childhood experiences, were experiences before the age of 18. So they asked them those questions, and they did this, by the way, in 1995 to 97. And you sometimes say, well, why are you telling us this right now? And the reason is because they looked at childhood experiences, and then they looked at the correlation between the illnesses that people were showing up with. And they thought that the higher the amount of childhood experiences, or actually of the experiences which were negative, the more chances of them of being sick. And we'll see on the slide some of those. Some examples of the questions, by the way, there's 10 questions, and I have the list here, by the way. You can Google it if you want to see all 10. The reason I don't show all 10, by the way, is because you may be reading it and adding up your ACE study, and I've done that in trainings before, and it's not such a good thing to do while you're at work or in front of people. So here's some examples. Did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you? They're yes/no questions. They're very specific, and that's one of the questions. Another question was, did an adult or a person at least 5 years older than you ever touch or fondle you, or have you touch your body in a sexual way? Were your parents ever separated to divorce? And it's interesting because in this culture, about 50% of marriages end in divorce, but in some cultures, divorce has more shame. They've done this around the world, and they found, for example, in China, which is a very, very large country, that when parents were divorced, there was it affected them.
Yep. Somebody writes in, there is a nexus between ACE and adult traumatic experiences and health issues. Absolutely.
Yeah. And I see.
And what about a parent's death? Is that one of the ACE study questions?
I have the questions right here.
It's an excellent question, because you would certainly think that loss of a parent through death or violence resulting in death would be very traumatic.
It would be. You know, ironically enough, it's not. But here's a couple of other ones that I can add. Oh, did you ever live with anyone who was a problem drinker? Actually, that'll be on the slide in a moment. Did a household member go to prison? Was a household member depressed or mentally ill? Or did a household member attempt suicide? So yeah, it is interesting, but loss of a parent at a young age, and especially a very young age, and probably at any age, is traumatic. Yeah, no, those were those, I chose 4 of the questions, and what'll happen is some of them will deal with what's going on in the home, and some of them will deal with the parents. And there's 10 questions, and I just showed you a few of them. Once I was doing a training, by the way, and we went over the 10 questions, and one gentleman said, I have all of those questions. I have yes answers. So it just speaks to kind of the commonality. I often use the example of, oh, who out there is a football fan? Please raise your hand. If you like sports, please raise your hand.
Okay, a couple of people are raising their hands. A couple.
All right, and if you don't, I'm going to use a football example. And there is a football player named Marshawn Lynch. He used to play for Seattle, although now he, I think, was just let off from Oakland. And when Seattle was in the Super Bowl, he would show up for interviews. He'd wear a helmet, or he'd say, I'm only here because I don't want to be fined. And he wouldn't answer, oh, Oakland, yes, he is from Oakland. And the I think they let him go, though. I'm not sure. But anyway, here's what's interesting. He grew up in Oakland, and if he were filling this out, by the way, if you're from Oakland, don't tell him, if you see him, don't tell him I've used him as an example. But I got this from ESPN, so I don't have to really deal with confidentiality. But he was talking about growing up in Oakland. His family was poor. His father took off when he was really young, and he was raised by his mother. And his mother would send him on weekends to hang out with his father. Problem was that when Marshawn would go to see his father would disappear for a few days. And he was a young guy, young boy, and didn't know if his father was coming back. Later on, one of his best friends was killed in front of him. And, oh, he's still with Oakland. Okay, cool. And he's actually given back a lot to the people of Oakland because he believes in giving back. And his story, though, his father's in prison now, had a drug problem, so that he has a high ACE score. So that's my example for those of you who like sports, and if you're from Oakland, yeah. So he's an amazing person. I like him. I used to always go visit Seattle pretty regularly, and people loved him in Seattle. But anyway, I don't want to talk too much about sports, but taking it back to trauma, is many of our clients have experienced the same things. So it's just, and actually it shows, by the way, that he could experience all of those things and still have a way of giving back to his community in a way that I think is really powerful.
You're speaking about resiliency.
It is resilience, yeah. So going back to some of the kind of the findings, and this pyramid kind of looks at what happens from early age, like adverse childhood experiences. So you can see on the left, it goes from birth to death. And when a person experiences childhood experiences, this is what might happen. They might be dealing with social, emotional, and cognitive impairment. And so many of our people are dealing with learning disabilities. They may adopt health risk behaviors. For those of you who work in the field of HIV, you see that a lot. Actually, as substance use as well.
Self-medication.
Exactly.
Yeah.
And then for many people, they may develop a disease or disability or other social problems. And for some people, there is an early death. Now, I think the key, by the way, is that there's a correlation, not a cause. So there's a difference, because what that could mean is that somebody started smoking early on. A young girl starts smoking at the age of 13. Later on, she develops lung cancer. So it was a correlation. But look at what they found. And I know that many of you are dealing with these illnesses or disabilities. So many of you are working with people around depression, attempting suicide, substance use, multiple sexual partners. By the way, I've worked in the field of HIV for many years and done a lot of training. There's nothing wrong with having multiple sexual partners. We often look at, for example, how to help people if they are having multiple sexual partners have safer sex, but people sometimes put themselves at risk. I think some of you are saying that you work with people who have domestic violence, liver disease, COPD, which is chronic obstructive pulmonary disease. So it includes things like emphysema, which people get from smoking, and heart disease. So in fact, one of the things that Anda and Felidi said was that if they had known a lot of those questions ahead of time, and they started asking those questions early on in primary care, maybe they would have avoided a lot of these things. So that is the study around the adverse childhood experiences. So let's go on the next slide to, we've already started to talk about this around risk factors and resiliency factors. And here's something that I think it's important to keep in mind. I know one of my trainer answers, by the way, is often, it depends. You know, sometimes people want really specific answers. And here's some things to keep in mind. What are the past traumatic events? How many have they had? What's the nature and intensity of events? So some obviously are more severe than others. They're also the duration of trauma. How long did it go? You know, you hear of people, by the way, being sexually abused from the age of 8 till 18. What's their age? The earlier it started, the more it's a risk factor. A history of psychiatric illness. Poverty, again, being a big one. So that, for example, and I think it's on the next slide as well, if you don't have access to good health care, if you don't have access to finances, and those were all things that you said, by the way, that you wrote in there, that the effects of poverty on illness and trauma are big, and discrimination.
Yeah, and somebody wrote in, actually, sexual orientation, which certainly could put someone at risk for violence or rejection.
Definitely. In fact, the studies, by the way, that I know from Korea is that for a lot of young LGBT people, that they experience bullying like 2 or 3 times as much as non-LGBT people. They get kicked out of their homes. There's a whole, and actually that getting kicked out of your home when you're 13 or young is really traumatic. We could do a whole course on that, by the way. In fact, what we may find, and you could let us know, is that if there's certain areas here which you want more training on, let us know. Now here's some more risk factors. Lack of social support, and we were saying how that's really important. Family conflict. Now, families do have conflict, by the way, but again, it's the extent of it. Housing instability. I remember somebody in my family saying that they always used to have to move in the middle of the night. And as a kid, I didn't understand what that meant till they couldn't pay the rent. And for many people that we meet, think about raising children in a shelter and what that might be like. Poor coping skills, learning problems, substance use, and that's why many of you are working at What to Do. So those are all risk factors for trauma. Now, substance use, by the way, it's by itself, by the way, is not a trauma. But sometimes what happens is some of the events that are involved in substance use can cause people to deal with some traumas. Negativity and pessimism. Again, this was taken from the National Center on Trauma. And I think sometimes people are born. You know, this is what I think. I don't know if you agree, Paul, but sometimes people are born optimistic and some people are born pessimistic. But sometimes some of the work, and again, this is my opinion, this is not an evidence-based practice, but that when you think about what some of our people have experienced, you can understand why people might feel negative and or pessimistic. Disappointment,
rejections.
Yeah. Yes. Lack of people being there for them.
Absolutely.
Lack of systems being there for them.
Abandonment.
Mm-hmm.
And that would certainly shape somebody's worldview.
Exactly. Yeah. So what are the protective factors? And I'm going to say, let's see what we've got written in there.
Yes, somebody writes in that lack of relevant social services that relates to the client's needs in terms of if LGBTQ individuals and cultural competence. If there are no social services available that will effectively provide services to those folks, they either are estranged from the services or they have a negative experience when they go.
Right. It reminds me of some work I did at a CREA last year, and they were asking people who were transgender, when you walk into a place, what do you think about? And they're talking about walking into a clinic. And the big things were, will the receptionist call them by their proper pronoun? Is there a bathroom that they can use? And those are things they had to think about wherever they went.
Right. And many folks, sort of cisgendered folks, are able to take that entirely for granted.
Right, because you don't have to think about it.
Right.
We could do courses on that as well. We have information on that. Protective factors, family support, could be blood family, by the way, or family that people develop. So a lot of times people develop strong friendships at Alcoholics Anonymous or Narcotics Anonymous or wherever they do that. Optimism and healthy self-esteem. Those are some of the things that you work with people on. A tendency to find meaning. I'm a vocational counselor by trade, and I used to help people find work that they loved or go back to jobs that they had and to be able to work with them. But I think whatever it is for people to find meaning is important. Everybody wants to find meaning. Curiosity and openness to experience. Aptitude. Economic stability, and those were some of the things you said before, that people don't have that, but it's I know they always do these studies on how much money you need to be happy, and I don't remember what the answers are, but the fact of getting a check regularly or something where you know that your food, housing, and shelter, your basic needs are met is really a protective factor. Employment, definitely, so having a job. Actually, employment is really good as a protective factor for relapse. Adaptability and spirituality. So the interesting thing about spirituality is that it may not necessarily be religion, but a person's connection with the higher power, however they look at that. And that has been a protective factor for many people. So those are some of the protective factors. And the good news is that many of you work with people to enhance them. So here's some other things to look at, is that trauma doesn't just affect our clients. And the topic we're going to be talking about briefly is vicarious trauma. And just as you look at the picture, by the way, it reminds me of sometimes of people who I see in trainings, but vicarious trauma is something that comes from outside and it affects the person inside. So people who work with people affected by trauma may be vulnerable to vicarious trauma. So it's like also called secondary trauma. So when you listen to stories of abuse, regardless of whether you've had them, those same stories, your continual listening to those stories can create vicarious trauma. What happens with vicarious trauma is it adds up. So it's emotional, it affects your body, it affects your spirit. And many people, for example, if you work in refugee programs, or substance use programs or child welfare programs. Sometimes people see some really horrific stories.
You know, it makes me think of when we asked people to write in what percentage of their clients actually experience trauma, and the lowest percentage we had was 50. So if half of your clients, and many of you wrote 99, 100, 80%. So, you know, working with folks who have experienced trauma and being exposed to that much traumatic content can really have an effect on you.
Somebody asked me when we're doing this course again, do you mean by webinar? I'm not sure if you're from Oakland or in person here in New York.
Yes, it can lead to burnout. Yeah, and burnout's slightly different than vicarious trauma. Oh, she was asking when we would be doing the vicarious trauma training again.
I don't have it scheduled, but I will, because I've been doing something on stress management and vicarious trauma. Please, yes, maybe for May we'll be able to do that.
Yeah, and somebody also noted, and I think that this is a very, you know, potentially unique experience that someone could have, is watching family pets abused. That sometimes that kind of exposure to that sort of violence can certainly.
Definitely. And for those of you who work in the field of domestic violence, that's another thing that sometimes the perpetrators do too.
To manipulate.
Yeah. All right, so what are some of the effects? And a couple of things come to mind. You may experience feelings of fear or vulnerability. Again, outside of the norm of what you might experience, you might have difficulty trusting. One of the things, I'm just going to look at a couple of these, it's different than burnout. So for example, if you take a sick day, or should I say mental health day, if you take a day off, I don't want to get anybody in trouble, or you take a vacation.
Or a personal day.
A personal day, and then you come back and you feel good, that's not vicarious trauma. That's usually, it could be burnout, but it's pervasive and it just doesn't go away right away.
And one thing I would also add in regard to that is that you had a different feeling, or you didn't have difficulty trusting before, but gradually you might start to feel feelings of fear and vulnerability that you can't really explain. Gradually you might notice that you're less trusting of people, or you might feel hopeless. So it really is that gradual,
right? And I think that's
sort
important.
Of transformation.
It's a transformation, and it may be slow, but it's happening.
It can
happen.
Yeah.
It does affect all areas of a worker's life. So for example, not only may it affect your job, but it also can affect your relationships at home, other parts of your life. Yeah. And that's why I hope we start to address it.
Yeah. I'll add one thing to that, which is that I recall once doing this training and participants talking about how certain clients, they realized they couldn't work with them because it was pushing their buttons too much, and they weren't aware of it at first, but then through supervision they became aware of it. Right. And you know, hopefully they were able to address it and develop a self-care plan.
Right. And that's the first bullet, the importance of actually staff training, or actually you'll see another bullet that says clinical supervision. Yeah. Because sometimes people think, oh, if I'm having trouble with a client, I'll just get rid of them, and sometimes you do have to do that, by the way, but you can't do it for everybody. And it gives the opportunity for growth as you do that. So it's important to have staff training on it. It's also important to process your own stuff on trauma. When I was teaching at NYU and I had a lot of young people, I used to say, go to therapy now. Deal with your traumas, because if you haven't dealt with them, they will come back to haunt you. So the healthier you are, the better you'll do at your job. Sometimes staff may use the same coping, so sometimes it's like parallel process, where for those of you who are supervisors, when you see your staff acting like your clients, have your antenna up. And again, the importance of clinical supervision. And I was telling Paul recently, and we've talked about how people don't get clinical supervision anymore. When I am in a training and I say, okay, who gets clinical supervision? Sometimes about 4 people out of 25 raise their hand. And sometimes clinical supervision ends up being administrative supervision, like when are you taking your vacation? And it's not. And so at least if you come, when I do the one-day course on stress, we talk about ways you can set up your own systems for that. And again, we kind of alluded to this, but you need to be aware when a client issue, when your client's issues exacerbate yours, and that
push
happens.
Your buttons.
Push your buttons, so to speak. So I think that's something to look at. So as we hit almost 1 o'clock, now we're on to what is trauma-informed care. So here's what we have. I think it's important to realize, and this is a term that's used everywhere. Everybody's like trauma-informed. And it's a system, and it looks at everything from the physical side. So like, do you have lights at your place? Do people have locks? If it's a residential treatment center, how safe is it? Is it in a safe area? Do you do groups, by the way, where there's privacy? Sometimes too, I've seen where sometimes people are short-staffed and they'll do a group on sexual trauma and they'll mix men and women in the group, and that actually is the opposite of trauma-informed. Going back to trauma-informed, it really recognizes how trauma impacts clients.
Somebody mentions the dynamic of transference and countertransference, and again, that's where supervision or trusted colleagues can be so helpful, because the great thing about human services is it's one person helping another person, and if you're working with another person, there's a possibility of a transferential dynamic.
Absolutely. And that happens as long as you're in the field, usually. It ensures safety in all interactions. And to me, the take home, by the way, on what is trauma-informed care is that, one, how do you create safety for people? And also, how do you avoid re-traumatization? Another thing that could happen is that you can look at yourselves in terms of a trauma-informed practice. Your agency can look at trauma, and also communities look at trauma. So I don't know if we have anybody from Buffalo on this week, but the city of Buffalo is working with first responders, with School of Social Work, to really look at trauma-informed care from a community point of view. And so I think that is important as well.
Yeah. One thing that's actually wasn't noted there is the idea of historical trauma, which is a critical component to also consider as well.
Exactly. And I don't know if it will go under some of the principles. What will happen is, in some of the books, you will see 5 principles of trauma-informed care. I have 2 slides. And so here's what you want to look at. We're going to recognize the impact of violence on coping, and people are doing sometimes the best that they can do. For example, I knew of a woman who was in a residential treatment center, and she was getting reprimanded by a counselor at dinner. She got up, she went to her room, she hid under the bed. Now everybody was saying, what's up with her? She's like hiding under the bed, and she was 26 years old. And what they found out later on was that when she was a kid and she was being sexually abused by her father, she would hide under the bed. So it worked for her, or maybe it didn't work for her as a child, but that coping mechanism, she was doing the best that she could.
Yeah, I was thinking the same thing. Somebody wrote in regression.
Exactly.
In terms of that, the sort of the reenactment or the re-traumatizing of the person causes them to regress to a coping strategy that maybe they used
and it doesn't,
as a child.
And it doesn't always translate well to what we expect sometimes, but to be aware of that.
And it's not an effective coping strategy.
Exactly. Yeah. To work from an empowerment model, many of you say you go into the helping profession to empower people. That's what we want to do. It maximizes consumer choices. For a lot of people who've been traumatized or they're victims of domestic violence, they didn't have a voice, they didn't have a choice. So that's really important, to give people a choice about, and it fits into motivational interviewing.
Absolutely.
Big time.
Yes.
And client autonomy.
Yeah.
It focuses on relational collaboration. What does that mean? Stephanie Covington writes a lot about the importance of relationships, especially in women's treatment. And old school was that if somebody went into drug treatment and said, I'm here for my children, counselors would usually reprimand them and say, you should be here for yourself, not for your kids. And now we know the importance, especially for women, although probably for men as well,
Sure.
that is really important. And that's a way, I mean, recovery often starts as an outside job. People get into treatment because their employer made them go, their spouse, their partner. They don't always go because they want to. And then recovery ultimately, you hope, becomes an inside job. So more principles, we want to create an atmosphere that's respectful of the survivor's need for safety and respect.
Somebody writes in the pre-contemplator. Absolutely.
Yep.
And again, part of a process.
Right. So, and in Counseling 101, they always used to say one of the biggest things that people want is to be respected, regardless of what they've done or who they are.
Absolutely. And that's a core principle of motivational interview.
Right. So it emphasizes strengths, which many of you do as well, minimizes the possibilities of re-traumatization. You know, how do we do that? Do we, one of the things that often happens is sometimes people walk into a treatment center and somebody's yelling, and that's re-traumatizing. Sometimes somebody tells you something that they were abused as a child and you don't believe them, or their mother didn't believe them. And another thing we sometimes do is that we make people repeat their stories over and over again. So it's important to really kind of look at that so that we don't re-traumatize people, and also look at why we're asking the questions that we do. Strives for cultural competence, and actually Paul started to mention, you know, if you look at historical issues, gender issues, that, you know, I sometimes think if you look at the effects of slavery on people today, they're there. The effects of Holocaust on future generations.
Yeah, the whole idea of, you know, meeting clients where they are, but also helping them to move to another place, not just leaving them there.
Right.
And that can be the real problem of like asking somebody to repeat their story. Right. Because if they're just telling you the story and it's not moving to some other place, then it's a problem. Right. And again, the idea of being client-centered and collaborative. Great.
And thanks for those write-ins.
Yeah,
this is really
excellent. Thank you.
Wonderful. Another thing is to solicit consumer input, and a lot of places will have consumer advisory boards. And so some of the things that people will say, I think, is really important that, you know, we might not have thought of. So that is also part of trauma-informed care. Here's some strategies, and some of you do this already, but telling people what you're going to do before you do it. So for example, you may be asking people personal questions, or the assessment's going to take about an hour and a half. It's important and respectful to tell them, I'm going to ask you some questions. You may not want to answer all of them. Another thing I used to see happen, that sometimes people would wait in an office like all day, and then they'd get called in to see somebody at 4 p.m. and they had to go home and take care of their children. So, and then they were written up as non-compliant. Another big thing around trauma-informed care is changing the question from what's your problem to tell me what happened. So it's really open-ended, tell me what happened, and also believing them.
And also not stigmatizing.
Exactly.
Yeah.
And again, seeing trauma responses as adaptations rather than manipulations. That was that example of the young woman who went under the bed.
Yeah.
But that we use the word manipulate a lot in our field. And if I look it up in the dictionary, you know what manipulate says? It's to get what you want. So I don't know about you, Paul, but I can say that I have manipulated. Some of you don't have to answer those questions, but we do what we need to do sometimes.
Yeah. And again, I really appreciate that they're using the word adaptations, because basically, think about it. A person has a traumatic experience, and given the resources that they may have at that particular moment, they adapt their behavior, they adapt the way they interact as a way to survive. And for some folks, that those adaptations may be things that ultimately come back and cause them, you know, health problems, life problems, relational problems. But again, the whole idea of that, you know, responses to trauma are an adaptation to attempt to survive what happened to them.
Exactly. Yeah. I used to have that when I was working with clients around, they would get a job, and then sometimes once they got a job, they would do things that they did as a child to survive, but they weren't acceptable in a work environment.
Right.
So
that whole notion of the regression in some way. Somebody writes in that the commentary keeps going in and out. Do you mean in terms of that your ability to hear us? Just to clarify? Okay, good.
Right.
Can you hear us now?
You can
Excellent.
hear now.
Thank
Okay,
you.
we
Good.
do have a mic here, but thanks for letting us know. We appreciate that. Actually, let me just look at the time. It's almost 1:10. Actually, you know what? I will ask you to do a write-in. And what other principles are you already practicing? I can go back and show them to you. So I'm going backwards. Let's go with the first set. If you take a look at those, what are some of those principles that you are already doing?
Empowerment, giving people choices, absolutely. It would be interesting to have people comment on empowerment, because people often talk about, I empower my clients.
Yeah.
Work with an empowerment model. Say a little more about what empowerment means. Can't really tell. We use sanctuary, so empowerment choices. Okay.
Right. The sanctuary model.
Yeah.
Yeah. Cool.
And consumer choice. A lot of people are talking about giving consumers choice. Connecting to resources that allow the person to feel more in control of their situation in terms of empowerment. Relational collaboration, absolutely. Giving choices, empowering the patients. Ask the client about what area of their trauma they want to work on. Again, giving them a choice.
Yeah. Right. And they'll tell you how safe they feel and what they're ready to do.
Yeah, and the idea of making sure that you're including a variety of choices that can help, so that they can choose basically from the menu if possible. Going over their strengths and allowing them to direct their goals. Affirming self-determination, absolutely. Strength-based voice and choice, cultural competence, and asking the client. Absolutely. Right. And letting the client guide.
Right.
Yeah, excellent.
Well, when we do one of the next webinars, Diana will be focusing on adolescents in the Latino community. So we also offer a lot of trainings here at NDRI on cultural competence.
Yeah, I really appreciate all of these comments. And somebody writes in another one, giving as much power to the patient to choose what works for them.
Right.
Okay. So somebody's writing in that they can't hear again. Okay. Can you hear us now? Okay, great. Thank you.
Good. I'm not sure what it is, but keep letting us know. Actually, I was going to ask you, Paul, a question, because
Sure.
You are one of the experts here on motivational interviewing. How does motivational interviewing fit into some of these principles?
It's funny that you'd ask that, because as I looked at these principles, I really thought, wow, these align so strongly with MI Spirit, because it's the whole idea of partnership, a collaborative relationship, being affirming and accepting of where somebody is, evoking sort of the solutions and the choices from that person, and then practicing compassion. So I feel like these elements really speak to MI Spirit.
Right.
Somebody writes in, seeking permission from the client before doing anything. Absolutely. Yep. Oh, somebody writes in that perhaps it's the weather that's causing the delay, where you can hear us and can't hear us. MI works because it allows the person to choose what works for them. Absolutely. And it draws the thing that works for them actually from them. And if we are going to make suggestions or offer information, we ask permission and then let the client choose what they want to do with it. And also, giving a rationale, letting the client know why we're doing what we're doing and why we're asking the particular questions.
Exactly.
So I think these key principles, Mary, do really align very effectively with MI.
No, I agree. And I was thinking that sometimes we ask questions because we're nosy. I mean, I've heard this in trainings, by the way, that sometimes people ask questions and they don't know what the purpose of the questions are.
And that would be, from an MI perspective, that would be MI incongruent.
Right.
And also something you might want to take to supervision.
Exactly.
Because ultimately, I mean, and I'm going to share my opinion on this, is I don't think we should be asking clients anything that's about our personal curiosity or agenda.
Oh, I agree.
We want to make sure that, you know, while we're asking questions, we want the questions to be purposeful and intentional.
I agree wholeheartedly. Let me go to the next slide. Some of you have started to do this. What would you add with these additional principles that you have done?
Some people have already noted the
Right.
cultural competence
Right.
piece in terms of being aware of sexual orientation, gender identity, gender expression, cultural background, racial background. Absolutely. Oh, somebody writes that it's thunder snowing in New York City. Well, our office has no windows, so we can't see that. That's good to know. Thank you.
And we wanted to make sure that we came here to do this webinar for you all. So
please define PGP. I think it's permission, give, or permission. What does PGP stand for? Ask the person's PGP. Oh, personal gender pronouns. Absolutely. Got it. Thank you. Yep. Yes. Or preferred gender pronouns.
Great.
Absolutely. Yep. Yes. Yeah. We often do that at the beginning of trainings that we do because we want to treat people with respect.
Right. At ACREA, we did it for every single training, but it's a good habit, I think, to get into. Anything else you'd want to put there?
Yes.
So again, that's an area that we can also, I think one thing about trauma-informed care is you can apply it to almost anybody, any area. I'll give you an example. One of my friends in Albany is a yoga teacher, and when I was there once and she asked me what I was training on, I was explaining what trauma-informed care was. And she said, oh, you know, we had a training today and we were told that if we were going to touch somebody, we should ask permission. I said, that's an example.
Absolutely. Yep. Somebody writes in, let the client lead and talk less and listen more. I like the direct and simple and profound clarity of that.
Definitely.
You know, when you were saying the thing about yoga and what the yoga instructor was saying that they were trained to do, it really made me think of what you had said earlier in the beginning of the training about how, you know, universal precautions in terms of this, you know, assume that everybody that we're coming into contact with has experienced some type of trauma.
Exactly.
And we want to make sure that, you know, all of our interactions are helping that person to achieve their health or life goals.
Exactly.
And not sort of, you know, silencing them or, you know,
right. It's kind of those
hurting them.
Things not to do, like not validating them, silencing them, telling them what to do. All right. We've gone over this one. And thank you for writing in all of those examples of things you're already practicing.
Yeah, and thank you for being so specific as well.
Exactly. Now, before we're getting towards the end, so I would throw out, what questions can we answer? What questions can we answer? We have a couple more slides, but it's more specific about some of the homework for tonight. Yeah. So what questions do you have over things that we went over today?
Yeah, or comments that you'd like to make
that could be helpful to us.
And we'll give it a little time if people are typing things in. And again, this is, you know, questions or comments, reactions to anything that we've covered so far today. Somebody, and this is really a practice strategy. Be present with your client, stop multitasking. Listening is a specific skill, absolutely. It takes a lot of energy and focus to truly listen. What types of body therapies do you find effective? Acupuncture, EMDR?
Yeah, tomorrow we'll talk about EMDR, and you probably already know what it is, or you wouldn't have typed it in, or maybe, but we'll talk about some of the practices that work. Acupuncture has worked a lot for people detoxing, a whole variety of things, and actually insurance is even paying for it. So what acupuncture does, by the way, is it increases endorphins, and for many of our people dealing with substance use, it can be really helpful.
Somebody writes in that the ACE study is so interesting. I think it could help in providing a lot of information.
Cool. There's a lot of websites about it. Somebody told me that there is a video on YouTube, which I haven't seen, but that I think is important.
Somebody writes in, have you seen the sanctuary model used clinically instead of organizationally? I can't really answer that.
You know what? I know or have read about the sanctuary model, and I don't know the answer, to be honest. I could maybe find out and let you know tomorrow.
Okay. And somebody also writes in, current workplace teaches the commitments to clients. Say a little more about that. What does that mean exactly? That clients agree to a certain code of behavior, or what exactly do you mean that it teaches the commitments to clients? If you could elaborate, that would be helpful. Somebody else writes in, New York Harm Reduction Education, NYHRE, provides acupuncture as a part of their street outreach. Yes,
Exactly.
absolutely.
Are you using the sanctuary model, by the way, for the person who wrote in?
I believe they are. I believe the individual said that they were using that model.
Yes.
Yes.
Okay. Mm-hmm. You may know more about it than we do.
Mm-hmm. Also, GMHC, Gay Men's Health Crisis in New York City, and I'm presuming that they also offer acupuncture. I think that's what you're referring to.
Got it.
Yes, okay.
Good.
Thanks for clarifying that.
Are there other questions that we can answer, or what questions can we answer as we start to wind down?
So again, as Mary was saying, you know, as we start to bring the webinar to a close, and feel free if there are other questions or comments that you want to make, please write them in. But I'm going to invite you to do another write-in. And before you do this write-in, what I'd like to suggest is that wherever you may be, take a nice deep breath in and let it go. And what I would ask you to write in is, when you think about what we talked about, what Mary covered, what people wrote in, when you think about that, what's one thing that stands out to you most about your experience of this webinar today? And so frame that in your mind and then type that in. And there are almost 40 people on this webinar, so let's get as many responses as we can possibly get. Just one thing that stands out to you about your experience of the webinar. Somebody writes in the power of silence with the client, and I would say, in terms of the work that I've done, that silence can be such a powerful and generous thing to allow in an interaction with a client, because it can allow the client to really reflect on what they're doing. And for some workers, silence is really a challenge. So silence is a muscle, it's a skill, and it's something that people can actually practice. So thank you for sharing that. Somebody also writes in that they felt that the webinar was informative and insightful. The many different types of trauma mentioned today, that very relaxed. Trauma is common, pervasive, easily accessible, the differences, traumas discussed, and the approaches offered. Okay. Are there any other thoughts about things that stand out to you about your experience thus far today? Yeah, that a safe space is actually needed for healing.
Exactly.
And thank you for, really identifying and saying that word again, because trauma-informed care, safe. Trauma-informed care, safe.
That's the key. I think I said before, if there's two things that you take home, one is how do you create safety? Second, how do you not re-traumatize people, which was also related to safety too.
Yeah. Somebody writes in, how to normalize trauma without re-experiencing it is difficult. Absolutely. The information, and it's interesting, I almost wouldn't use the word normalize. I might frame it as how to integrate trauma.
Exactly.
And, move beyond it. And that is difficult. And I understand why the word normalize might be used there.
Right. We'll talk about that tomorrow also, about what you can do and what you can't do.
Yeah. Somebody writes in, the information was clear and helpful. Good. Thank you for that feedback. People can recover from trauma. Yes, that's something that really stands out to me. Again, having heard this webinar and participated the second time, is how important it is to actually hear and know that. Self-awareness is crucial to self-care, but also for ensuring that we can be really present for our clients. Yes, not re-traumatizing clients. The thing that stands out to me is the importance of not re-traumatizing by having people retell their stories. Okay. The world is full of traumas. How can help be provided to those that struggle to move forward in a wholesome life? Yes. As the overall comprehensive information, okay. Thank you for highlighting that it is not just our clients affected, and that the need for supervisors to approach their supervisees with this awareness. Absolutely. Because supervisors don't want to re-traumatize their supervisees. Not re-traumatizing clients, and ways to provide safe practices for the clients. I feel the definition of trauma was narrow. Okay. All right. And we can certainly talk more about that in part 2. Okay. And thank you for that feedback. So again, people are more than welcome to write in anything else. As trauma is subjective, yes, it's extremely subjective, and it relies, as Mary covered, on a variety of factors and elements.
Someone else knows about Marshawn Lynch. Yay!
The importance of understanding, and the importance of understanding vicarious trauma. Absolutely.
All right. For one of the second to the last slides that we have is, I'm going to give you some homework, and it's due tomorrow. So sorry if you had made it last week, you would have had a week to do this. But here's what I'd just like you to think about. As you return to your agencies, or you are at your agencies, please observe, what is your agency doing that is trauma informed already? So look at physically what's going on, maybe in terms of socially, psychologically. Sometimes, for example, counselors are trauma informed, but the maintenance workers are not, or the receptionists are not. And I kind of always joke about receptionists in New York, although many of them are really nice, but sometimes people go into an agency and they're yelled at by somebody who is right in front of the door. So anyway, so just take a look. And as we start tomorrow's session, we'll start to ask you to look at what the homework was and what your agency is already doing.
Yeah, and somebody also wrote in, would the slides be sent to our emails? Absolutely, we can make these slides available. And I do want to add just one other technical thing about tomorrow. The folks that are attending this webinar are the folks that actually got closed out of the first delivery of this because of a problem with our webinar platform. You received 2 emails. The first email was the link for registering for today's. So wonderful that you were able to get on. We're so glad we had the opportunity to work with you today. And you were also sent a second link. And that link is the link that you will use for tomorrow's webinar. And the way that you can be sure that you're using the right link for tomorrow is that it ends with the numbers 6866. So just be sure that when you join tomorrow that you're using the webinar that ends, the webinar link that ends with 6866.
Thanks, Paul.
You're welcome.
All right, so this is the end of part 1. So part 2, we'll see you tomorrow, or we won't see you. We'll welcome you back tomorrow at noon, and we will do part 2. And then we'll repeat again tomorrow the piece around sending out evaluations so you can get your certificates.
Right, because in order to get the certificate, everybody has to fill out an evaluation.
Exactly. So I want to thank you very much for your patience and for coming back, and I hope that it was helpful. And I want to thank Paul for sitting in, and Clyde, we thank you for your technical assistance, and that's why we can do these. And somebody wrote in, thank you, New Yorkers, get home safe.
Yes, thank you. Beware the thunder and snow.
Right. I think I'm leaving soon after. So again, we wanted to make sure that we got back to you with this webinar.
Thank you so much for participating today, everybody.
You're welcome. To all the people who just wrote in, thank you.
Yes, absolutely.
All right, we're signing off.